Okay, so the main aim of the quantitative study was to assess preferences for lung cancer treatment attributes by calculating two main indexes, the maximum acceptable risk and the minimum acceptable benefit. The first index, maximum acceptable risk, basically describes the maximum level of risk that the patient is willing to accept in terms of toxicity or side effects in exchange for an expected benefit. In our case, we can say survival. The minimum acceptable benefit is instead referred to the minimum benefit that the patient would expect for a switch from a therapy to another that implies more toxicity or more side effects. The other aim was to investigate variables that might explain preference heterogeneity, such as psychological constructs, demographic variables, clinical variables. And finally, assess the usefulness of the educational tools, as Meredith already presented in the previous presentation. So the quantitative study was conducted in two different cancer hospitals in two different countries, Italy and Belgium. And we enrolled a total number of 307 non-small cell lung cancer patients from stage 1 to stage 4. We invited them to fill in an online survey. So the survey was composed by questionnaires, by educational tools, and two different choice tasks, the discrete choice experiment and the swing weighting. Next slide, please. Here I would like to introduce you the structure of our survey. So we started with some demographic and clinical questions, of course, to know the overall current situation of patients, followed by the educational tool introducing the attributes and one educational tool describing how to perform the first choice task. And then followed by one of the two choice tasks. Consider that we randomly proposed to patients the two different choice tasks with a crossover design ABBA, in a way that first patients, for example, had to perform the DCE followed by the swing weighting, but other patients performed the swing weighting, then followed by the discrete choice experiment. After the first choice task, some feedback questions were proposed, questionnaires related to the psychological constructs, health literacy, and health locus of control, then followed by the second choice task and a final list of feedback questions. Next slide, please. Okay, this is again the picture representing how we displayed the survey to the patients, the educational tools, the two different choice tasks, and the feedback questions in the form of the Likert scale. Next, please. Our sample was composed by an equal number of males and females, and their age ranged from 55 to 64 years old, and from 65 to 74 years old. I would say fully representative of what has already been observed in the clinical practice and in literature, since lung cancer is mainly diagnosed when people are 65, from 65 to 70, we would say. This happens because the main symptoms of lung cancer are cough or shortness of breath, and these symptoms are common to many other diseases. For this reason, the most of the people are not checked for lung cancer, since the cancer is already spread in lungs and also maybe in other parts of the body. I would focus on other two social demographic results of our sample. The fact that we had almost an equal number of people that were at stage 1 and 2, and people at a later stage of cancer, 3 and 4, in a way that we were able to compare preferences depending on the level of cancer stages. And also depending on the lines of treatment. We had almost the equal number of people that never underwent lines of treatment different from surgery, for example, and people that had instead extensive experience with other different kind of treatments and underwent from 1 to more than 3 lines of treatments. Next, please. Some key findings. Concerning the overall preferences, we found that all patients preferred survival over any other kind of aspects, any other kind of attributes. And in terms of trade-offs, patients were willing to accept a substantial increase in the chance of developing side effects in exchange for the slightest chance of surviving, at least 5 years after the diagnosis. Just to make an example, our patients preferred for a 1% point increase in the probability of surviving. They preferred high probabilities, like 8.5 increase in the probability of suffering for severe side effects such as long-lasting skin problems or fatigue. About the MAB instead, the patients expected to obtain a considerable increase in the chance of survival, to accept a switch from a therapy to another that had worsening conditions in terms of mode of administration and hair loss. But in our study, we obtained that these were the less important aspect for them. Next slide, please. This is a graph representing what I said, I described it before. As you can see, the column related to the survival attribute is the most important one for all the participants, followed by all the other aspects related to the side effects and to the mode of administration. Concerning preference variability, we found that 2 classes of patients explained variability in preferences. Please, next. Class 1, that was composed by people with high health literacy and high education level. Next. And class 2, that was mainly composed by elderly patients and patients with high internal and chance loss of control. This means that preference heterogeneity in our study were explained by age, literacy, and loss of control, basically. Next slide. We didn't find heterogeneity instead for country, cancer stage, or lines of treatment, having children and quality of life. I would like to focus on the results related to cancer stage or lines of treatment. Indeed, we expected to find variability in preferences due to the cancer stage, early stages versus later stages, and lines of treatment, because we expected that people that already had an excessive experience with the treatments, or people that are at a later stage of cancer, would prefer survival more than people at early stages. Why I say that? Because usually for the early stages, for stages 1 and 2, surgery is possible to fight cancer. And apart adjuvant chemotherapy, these people have a different experience in terms of life expectancy and prognosis compared to people diagnosed at a later stage for lung cancer. Also, the clinical pathway is different, but we didn't find heterogeneity. So many hypotheses are possible in this case. And one of these is that some massive campaigns about the mortality, the level of mortality and poor prognosis of this cancer affected the perception of the seriousness of this disease. And we obtained that people, when they are diagnosed for lung cancer, we can hypothesize that when people are diagnosed with lung cancer, independently by the cancer stage, are worried about their life expectancy and survival. Next slide, please. Okay, some key conclusions. So lung cancer patients are so physically and psychologically fragile that their main concern is to increase life expectancy when they have to choose for a therapy. But another hypothesis that we did is that it is also important the way we present to them the different attributes, and in particular the way we presented to them the attribute survival. We presented it using a positive framing, giving less importance to the severity of the side effects. This maybe created a sort of anchoring effect. So when they had to choose between different scenarios and therapies, patients anchored their attention to what was most important to them, survival. Preferences were found to vary based on age, education, and health literacy. And in particular, we obtained that patients that aged 65 and over gave higher value to the side effects compared to people with high literacy and high education. This may be happening because elder people usually are give more importance to their daily functioning and to their quality of life, and are more worried about the way side effects can affect their daily functioning. Younger patients instead, and patients with a higher level of literacy and education, had a different preference related to the mode of administration. They preferred to take a pill versus having an infusion compared to the rest of the participants. And this may be interpretable in terms of the fact that they belong to the working class. Younger patients belong to the working class, and going to an hospital for 24 hours of infusion takes time from family and work and many other activities. Next slide, please. Some key learnings by performing our study was that we had, for us, it was really challenging to translate the open-ended results that we obtained in the qualitative phase, in the qualitative, using the qualitative methods, into the discrete attributes and attributes levels that we used in the quantitative study. Because the risk is to lose a lot of information, important information, that instead can arise in an open discussion with the patients. The other aspect, important aspect, is that we underestimated the importance to involve caregivers and physicians in engaging patients to participate to our study. Even considering the current pandemic situation, we had to perform our study using an online survey, and caregivers were really important to raise the interest of lung cancer patients that are already, as I said before, fragile and vulnerable and worry about their life, to highlight the importance to participate to such kind of studies. Next slide, please. Okay, some instead strengths of our study are, for example, a robust design, the fact that we used two different preference elicitation tasks to compare results between two tasks, and comparison of two separate countries in order to control possible differences, to cultural differences, and the participant feedbacks. Next slide, please. I would like to thank and acknowledge all the people that participated to our study. Next slide. And this is a list of currently available publication that we have for lung cancer case study. We have currently in preparation the paper related to the publication related to the main clinical results of the quantitative study.